Welcome to the 2021 National Center for Wellness and Recovery Annual State of Addiction Panel Discussion. I'm Dr. Casey Schrum, President of Oklahoma State University and founding member of the National Center for Wellness and Recovery. I'm honored to have with me today Reggie Whitten and Dawn Kyle. The shame and stigma associated with opioid use disorder keeps many individuals from seeking treatment. Patients are many times seen as bad or weak people making bad choices. However, substance use disorder is a brain disease. It is a disease that does not discriminate. Undoubtedly, we still have a lot to learn about the science behind addictive behaviors and substance use disorders. But make no mistake about it, the National Center for Wellness and Recovery is committed to finding the answers. Scientific discoveries lead to understanding and opening doors to better treatment options, access to care, and most importantly, hope for those individuals and their families who are struggling. Reggie Whitten is a passionate advocate for addiction education, treatment, and awareness. After meeting Reggie in 2012 and hearing his personal story of how opioid addiction devastated his family and the lives of so many in our state, OSU began taking action to change the way we were educating our physicians about addiction and pain. This eventually led to the formation of the National Center for Wellness and Recovery. Reggie is also an adjunct professor at the OSU College of Osteopathic Medicine. Reggie, I know in 2012 when you shared your story with me, it had a big impact on me and the way I thought about addiction. So would you care to share your story with our viewers today?
Well, I'd be happy to, and thank you for having me here today and for having my friend Don Kyle be here. He's an amazing guy. And so I'd like to introduce my audience to someone that I think of as my co-speaker. This is my son, Brandon Whitten, and I think you're seeing a slide right now of him when he played high school football. He went to Westmore High School and graduated from there, was a pretty darn good athlete. I was extremely proud of him, not only through high school, but through college as well. This is a couple of pictures showing that at one time, indeed, I did have hair. This was me and Brandon when he was little enough for me to pick up. And I was a very young father. I learned everything kind of on the job, so to speak. And Brandon had a normal life. These are two of his 4 siblings. Playing around in the swimming pool. I thought he was the ideal kid, and we were very, very close. And as he grew up, he turned into a good student, and he turned into a really good athlete. He played on a Division II national championship team, and he's shown here in this picture with 2 others of his siblings, and this young lady in the picture actually graduated from OSU Med School and is a doctor today. But my point is, everybody loves their children, and I thought Brandon was just such a great kid. And our plan was for him to go to law school and become a lawyer and probably practice law with me. That's really what I thought would happen. But that was not to be, because we ran into something that neither he nor I understood, and nobody in our family understood it either. So I'll tell you Brandon's story real quickly here. I also can address some of the things Dr. Schrum said about the stigma of shame, because I lived through that, and Brandon lived through it. Our whole family lived through it. This is a picture of Brandon playing college football, and I've looked back through all these pictures of him many, many times, and almost always Brandon had a big smile on his face. But looking back, he didn't have a smile at this time and in this picture. And I didn't know it at the time. He had developed an addiction, and we kind of found out the hard way that he did that. So I got a call at midnight one evening and was told that Brandon had been in an accident. And he was driving this car that landed upside down in a little creek, and he and his lovely 20-year-old girlfriend were suspended from their seat belts, and you can't really see it in that picture, but there was a little creek there, and they almost drowned. So I went to the hospital, And by the time I got to the hospital, I ran into this young lady, and she was sitting with her mother in the ER, and she didn't have a mark on her body, and they did have her intubated. And you know, my first thought was, thank goodness she's okay. I then turned my attention to my son. He was in a different room, and it appeared that he had been more seriously injured. He almost lost his right arm, had compartment syndrome very badly, and as the days went by, Brandon recovered enough to get out of the hospital. And of course, you know, like any father, I wanted to know what happened, because he was an excellent driver. And the story that I was told by Brandon was that he had been taking prescription pills. He didn't have a prescription for anything because he didn't need them. He told me later that the boys in the weight room at school after practice were passing around a bottle, and that's how he ended up getting addicted. And of course, this fateful night, he had been taking some of those pills, and he had been driving, and that's how they ended up upside down in that creek bed. As a father, of course, I was very disappointed because Brandon had been raised right. He knew what to do, and he knew the difference between right and wrong. This behavior was very foreign to me. And then matters got far worse. Like I said, Brandon got out of the hospital, but this young lady did not. It turned out I got introduced to something else I didn't know anything about. She had MRSA that somehow got in her lungs from from this dirty river water. And she ended up 3 weeks after this accident passing away as a result of this accident. So both of these families' lives were just shattered. And now Brandon had pretty bad survivor guilt. He truly loved this young lady, as did I. So that was my first funeral that I ever attended for a young person. And if you haven't experienced that, it's different. And so after that, I turned my attention to my son. His situation had now changed in many respects. And I learned that he was addicted to these pills. And at that time, I didn't really know the difference between an opioid and a benzodiazepine. Turned out Brandon had taken both. But I think the drug that ultimately led to the end of Brandon's life was his use of opioids. And that's what he preferred taking. So time goes on, and for the next 3 years, we lived through this. I kind of like this diagram because that's what our life felt like. It was kind of a roller coaster. And until you've experienced a deal like this with a loved one, it's very difficult to make others understand it. But when I looked into my boy's eyes, this boy that I had raised, and he would vow to me that he would never take them again, I believed him. I think he believed what he was saying. But for some reason, this behavior over the next 3 years was inexplicable to me and to his family and his friends. He just couldn't stop. And this young man who had all this willpower all of a sudden was unable to control the trajectory of his life. And things would be going along great, and then all of a sudden he would fall off the wagon and he was back on those pills. And it was a devastating body blow to the entire family, but to Brandon as well. And so that's what we dealt with for about 3 years. And so you fast forward to the end of that 3-year period. This is the last picture ever taken of Brandon. He had just loaded his baby sister into the back seat, put her in a car seat. And we were having dinner with friends, and somebody in the family snapped this picture. And he and I were supposed to actually get together the next day. And he called and told me he could not be there. And during that 3-year period of time where he was taking these pills, I had kind of become a walking slur detector. I could tell he was taking them. This was at noon on a work day. And so he knew that I knew. And I asked him where he was at. And of course he lied to me and told me somewhere else. And I said, you stay right there, I'll be right there. And I was angry because I couldn't understand this behavior. And I drove as fast as I could to that location. Of course he wasn't there. And I couldn't find him. I called his phone to chew him out. I couldn't get him to answer. So I ended up going to my home thinking that maybe he had headed there. It turned out I was right. He had headed there very quickly with a friend. And when I pulled in the neighborhood, I could see ambulances and fire trucks and all kinds of police cars. And I saw this motorcycle, which I did not recognize. I found out later that was my motorcycle. Brandon and I were avid motorcyclists, and he was racing home, and about 100 yards from our house, he hit a brick mailbox, and there were just bricks all over the street. And that's, they loaded Brandon in a helicopter apparently minutes before I got there. And he died in that helicopter as they were trying to get him to the hospital. And when I got to the hospital, of course, I got to see him for the last time, and it was very obvious he had died of a head injury. And that's what his death certificate said. But the motorcycle didn't kill him, and the head injury really was just an incidental thing. What really killed him was his addiction. I believe that with all my heart. And so that's the end of Brandon's story. That was the end of his life. And that was back in February of 2002. So after that, I've written a lot of things, but I'd never written an obituary. And I attended the second funeral of a young person. And that's not the last funeral. Since that time, I've attended a number of other funerals caused by the same thing. And it's really hard to put somebody's life in a few short words, but that's what I had to do that day when I wrote the obituary. I'm still very proud of my son today, and this picture here is how I like to remember him, because really, virtually all of his life he was smiling until he got addicted to those opioids, and everything changed. Sadly, the number one person I talked to was a friend of mine, my family doctor, but neither he nor I really knew what to do about this. And for the general public, it's a very challenging topic to figure out what to do in something like this. And this situation was the most challenging situation I've ever run into in my life. And you know, Dr. Shrum mentioned the stigma of shame. I've had other family members who have had cancer, and when your loved one gets cancer or any disease, really, you will feel the warm embrace of their love. People will come over to your house and bring food. They'll put their arms around you and tell you they love you. But when you or your loved one gets addicted, it's a totally different thing. There's nobody coming to your house. There's nobody giving you that warm embrace, because they're all ashamed. They're ashamed of the behavior of the person who is addicted. There have been studies, I know now, done on this subject, and people don't want to associate with someone that's addicted. They don't want them in their homes. They don't want them in their businesses. And indeed, some doctors feel the same way about their patients, and they don't even want to treat them. The same goes for my profession, lawyers. We tend to blame the victim, and I can't think of another disease where people react this way. If, my brother was a diabetic, no one was ashamed about that. No one told my brother to use more willpower and not need that insulin. But that's all I ever told my son to do, because that's all I knew to do. Just use more willpower. You don't need that pill. And I didn't know then, but I know now, people like my friend Don Kyle, they study this. And the National Center for Wellness and Recovery here at OSU, they study this. And we know now that it is a disease of the brain and that this drug over time changes the chemistry of the brain. The brain is a chemical and electrical machine. And the general public doesn't understand that. I didn't understand that. These people who become addicted lose their free will to some extent. And that's why you see bizarre and often bad behavior from these people. And I will never forget, I like putting this up here on the screen. This is what Brandon told me. Dad, nobody ever told me I couldn't stop. And of course I feel a lot of guilt over that because I didn't tell him that, because I didn't know it. So I've spent the last 19 years trying to obsessively read about this, and I've learned a lot. I'm just a student of the game, but I know we have to do something. And I don't have all the answers, but I believe with all my heart that education on this subject is the key. And I believe lives can be saved if we educate our legislators, our general public, our leaders, even our doctors. Everybody needs more education on this particular subject. And that's why for the last 19 years I've been out here advocating that we've got to do something different. Don is going to talk about the science behind this chemical change to the brain. He understands it. And we've got to all try to understand this better. I'll close with this slide. I ended up helping to make a documentary film called Killing Pain. And episode 2 talks about the chemistry and the science behind addiction. I will also add that during the COVID-19 crisis, this situation has made the addiction crisis even worse. And we have an episode on that as well. I hope you get a chance to watch it. So I'm going to kick it to Don and let him explain the science of addiction. Thank you for having me.
Well, thank you, Reggie, for sharing your story and for the work you do. It's I think the work you do really prevents others from hopefully having to go through what you and your family experienced. And I think sharing is important, and the more work we do at the National Center and learning and as you said, education about addiction as a disease is important. So Brandon's story and others like Brandon are what really kind of fuels our passion and determination to find answers. And that, because that's what inspires hope, the development of new solutions and science-based treatments. So with that, Dawn, I'll let you go ahead. And Dawn Kyle is a lead researcher at the National Center for Wellness and Recovery. And as we mentioned previously, substance use is a brain disease that doesn't discriminate. And having kind of listened to Reggie's story and Brandon and many stories are similar to that. Can you talk a little bit about the science behind the behaviors of addiction and the progression of the disease?
Yeah, I can. So thank you very much for inviting me, Dr. Shrum. This is such an important opportunity, and it's just a real privilege for me to be part of the group here. And I've heard my dear friend Reggie's, I've heard his story before. It breaks my heart every single time I hear it. And science doesn't have all the answers at this point. More research is needed to try to figure these things out, to develop best practices and educational materials for families and physicians. And it's just such a heartbreaking story, Reggie. I'm so sorry for you and your family. But Casey, let me start off with, Dr. Shrum, let me start off with something that you mentioned early on and Reggie also reiterated, and that's this issue of stigma. And stigma is really, I would say stigma is a real killer, almost as much of a killer as the drugs themselves in some ways, because they prevent people from seeking out help that they need. And stigma really has been demonstrated now to really reduce positive health outcomes in opioid use disorder especially. And there's lots of different types of stigma, and I thought I would just lead off with just a reiteration of some of the things that you said earlier. There's what I would call societal stigma, which is, the societal norm, which Reggie alluded to. Stigma against people with opioid use disorder. It's a character flaw. People think it's a character flaw, or it's a lack of personal responsibility, or, suck it up, you figure this out, this is your problem, you have to solve this, be strong, or maybe you're even a deviant. And even among physicians, as Reggie alluded to, there's sort of a treatment-averse mindset among some physicians, like, I don't want these people in my office because they make my office look bad. The other patients might not feel so comfortable. That's a societal stigma. And ultimately that leads to what's known as an internalized stigma or a self-stigma. Dr. Shrum, you mentioned this earlier. This is the shame and the low self-esteem. And the individuals who have self-stigma, they have a reduced hope for recovery, and actually a reduced interest in seeking help. And even if they do seek help, they have a reduced adherence to the treatments. They don't want to be there. And in fact, and unfortunately, an increased suicide risk. There's even stigma about treatments for opioid use disorder. And there are 3 treatments. 2 of them are actually opioid agonists, methadone and buprenorphine. And a lot of folks believe that these treatments, which are known to be effective for treating opioid use disorder, some folks feel that it's just substituting one opioid for another, and it's not really solving the problem. This is a mistake, and this mistaken view has really contributed to the low implementation of medication-assisted therapy in the healthcare system today, and it's very strong in the justice system, I believe. And then just very recently, I thought I'd mention, about 1 week ago, the director of the National Institute of Drug Abuse, Dr. Nora Volkow, published a paper in Neuropsychopharmacology talking about what I'm calling the inadvertent stigma associated with the words that we use in our day-to-day lives as scientists and physicians. For example, we might refer to somebody as an abuser or a drug abuser or an addict instead of a person with opioid use disorder, emphasizing that they're a person first and they have a disorder. Even the word abuser it has a stigma associated with the word abuser, and could better be said as something like instead of abusing drugs, they're misusing drugs, or they're using drugs. Also, clinical testing for opioids, they can be described as clean. The test was clean, or the test was dirty. There's stigma associated even with those test results that's just part of our vocabulary that is not helpful in this situation. Even the word medication-assisted treatment, MAT, is a stigmatized phrase because it suggests that it's a medication-assisted treatment, and that treatment by itself isn't enough. And it's far better to say that this is a medication for treating opioid use disorder, just like you would say this is a medication for treating cancer, or this is a medication for treating a headache. Well, this is a medication for treating opioid use disorder instead of a medication-assisted treatment. Anyway, Dr. Volkow has a very interesting paper published just a week ago, and I would refer people to look that up for a very long discussion on this subject of our scientific nomenclature. So I thought I'd lead off with that and reemphasize some of the things that you said, Dr. Shrum. In fact, addiction is a disease of the brain, as we've talked about already, manifested by compulsive substance use despite harmful consequences to the individual who is using the substances. That's the definition from the American Psychiatric Association. So what I'd like to do is unpack that a little bit. It's a disease of the brain, and there's compulsive substance use despite harmful consequences. It's very unnatural, so let's unpack that. On this illustration that I think everybody can probably see somehow is a phrase that I like to use a lot. The human body is the original information superhighway. The human body is a network of sensory neurons. They run all through your body, and they send signals about the status of your body, as well as the external environment that your body is in. All of these signals through our senses are going up to our brain, and the brain is translating these signals into perceptions. And those perceptions are translated into decisions and actions and even memories of the event that we can reference later when we're making new decisions. For today's purposes, I'd like you to think about interconnected brain regions that are pivotal to this decision-making and motivational process. And the three parts of the brain that I'd like to just identify have to do with memory. And there's two sections there, the hippocampus and the dorsal striatum. But just think memory for now. The decision-making is primarily done in the frontal part of your brain, the prefrontal cortex, and some associated structures. And then the value of a certain stimuli is assigned primarily by the actions of an area called the nucleus accumbens. And let me talk a little bit more about each of those to try to explain how these three areas of the brain can be hijacked by drugs. So this is a little schematic that I made that shows how a stimuli can interact with our sensory nervous system, and it can produce value in the nucleus accumbens, and this is done by elevations of a chemical called dopamine, which is released into this region of the brain. It's the so-called reward center of the brain. And if it's something that you like and it's favorable and it feels good and all of that, a strong memory association is also formed, linking that activity or that substance with, with the event and the memory. For example, stimuli that cause dopamine surge in the nucleus accumbens, they are considered to be high value. In other words, things that you would want to repeat again. And this is crucial for human survival. For example, sex or eating trigger a dopamine surge in the nucleus accumbens, and it's a very rewarding experience, and you generate a motivation to actually keep repeating that, and that's essential for human survival. But other things like learning, socializing with others, a good conversation, a good book, all of these things will give you a transient boost of dopamine levels in this reward center, and memories are associated with that. Opioids and stimulants can hijack this system and the decision-making circuitry that goes along with it, and Reggie, that begins to get into some of the behaviors that I think you were observing in the story that you told us about Brandon. So let's make a simple example here. Let's say that after this meeting is over, we all go out and we have a big bowl of ice cream together at your favorite restaurant.
Right.
That's a really big bowl of ice cream. And we eat that ice cream, and it tastes great, we feel good, and we have a good conversation, and it's absolutely wonderful. And you get a very strong memory, like, man, I love eating ice cream, I would do it again. Now fast forward maybe a week or 2 weeks or something, and now your body is sending signals to the brain like, haven't eaten for a while, I'm kind of hungry. So your brain will start accessing these memories about food. What do I feel like eating? And that ice cream was a strong rewarder, a strong reinforcer. That's going to rise right to the top of the list. I really want ice cream. Tasted great, I was really satisfied, I'm starving right now, that's going to be great. But in the frontal part of your brain, the prefrontal cortex, which is the executive decision-making center, you can overrule that craving. And you start thinking, yeah, I really want ice cream, but you start thinking about the consequences of that. And you decide, I'm going to have chicken. I'm going to have baked chicken. I'm going to bake my chicken and I'm going to eat that. That's probably better. And you override the craving. And that is an executive decision-making function that your brain naturally will do. And then everything else is about setting up and preparing to get the chicken and then carry out the action. That's a normal brain, and that's how things kind of work normally. Now, those surges in dopamine that I was talking about for natural stimuli like eating and socialization and things like that, they raise dopamine levels in the nucleus accumbens about in the range of 200 to 300%. Drugs that are commonly abused, like opioids and stimulants like amphetamine, as shown in this illustration, really raise the dopamine levels up 800 to 1,000%, remarkably higher than the so-called natural. And they're not only higher levels of dopamine, they're sustained for long periods of time. So there's a big difference between the drug-induced elevation of dopamine and sort of the natural stimuli-produced dopamine. And now this illustration shows in red how these drugs can hijack and affect this decision-making circuit that I just described. So repetitive drug exposure causes adaptations, including the loss of dopamine receptors. That's the protein the dopamine chemical has to bind to create a pharmacological response. The number of dopamine receptors on the neurons drops way down. Now, the natural stimuli like eating only causes a small transient elevation of dopamine, and so with less dopamine receptors to bind to, the circuits become less sensitive to the natural stimuli. The drug, on the other hand, is giving you a very high dose of dopamine in the accumbens, and that becomes your focus. And the motivation to pursue natural stimuli, which includes, sex or eating or conversation or reading or learning new things, the motivation to pursue that is diminished. And your entire focus begins to shift to the drug of abuse, which is, giving you a larger effect in this reward pathway. The drive for the drug is strengthened because you start repeating the drug use, and that gets repeated over and over and over, reinforcing those memories. And there's no competition for that because the natural stimuli are not really being practiced anymore. So pretty soon, everything is about getting the drug. And family relationships, good decision making, it all sort of disappears in this case. Now, the loss of dopamine receptors in that executive decision making center, the frontal cortex, also impairs its function. And so you no longer have the ability to make a decision. In other words, you can't choose the chicken. In this case, all you can choose is the drug. The substance that you're using is all you can choose, and that's the priority of your life. All motivations are aimed at that, and that is what leads to the compulsive drug intake. This is how the opioids and stimulants hijack the system. Two things I want to mention quickly here. I want to dive into the memory a little bit. I mentioned the hippocampus and the dorsal striatum. This is really important. Just think about them as two separate parts of the brain. The hippocampus is responsible for what's known as the cognitive memory. You're actually referencing that when you're making decisions. It drives purposeful behavior. So for example, when you're first learning how to drive a car, you're really following the instructions and where are my feet and where are my hands and where are the other cars. You're very attentive to this purposeful behavior. Over time though, as your brain does the same thing like driving year after year after year, that action shifts into the dorsal striatum, which is more of a habit memory. Some people refer to that as a muscle memory. You don't even have to think about it so much anymore, it just sort of happens. And I'm sure we've all driven somewhere and not even remember getting in the car and driving there, but somehow there we are. That's because that act of driving has shifted over to habit memory or an autonomous behavior. What's interesting is it's been shown in animal models that the purposeful behavior and the cognitive memory is inhibited by opioids and by stimulants. And the habit memory is facilitated by stress. And the cognitive memory and the habit memory are in sort of an equilibrium with each other. So drugs like opioids or stress or both together push this equilibrium more to the habit memory, and it becomes like an autonomous behavior. It becomes the natural norm. So there's new research that indicates that once acquired, habit memory could be suppressed. And this may offer new approaches to reversing the habit memory form of addiction back to something that's more normal in the future. It's emerging science. I made this schematic to show kind of the patient journey. So patients in pain pain is the #1 reason why people go to see their doctor, and the doctor may decide after evaluating the risk-benefit to prescribe an opioid to this patient. The benefit, of course, is the alteration of the perception of pain. So the doctor can relieve the pain by prescribing an opioid. But There are risks that also have to be considered. Which opioid is being prescribed? How long should the patient be on the opioid? What dose should be used? And then some unknown things about the genetics of the patient or the environmental factors where the patient lives and who the friends are, and other unknown things. Those risks lead to the neuroanatomical changes that I just described, ultimately leading into opioid use disorder if we're not careful. So there are urgent needs for patients struggling with chronic pain and substance use disorders. And I listed 3 of them on this slide because this is the framework of the research at the National Center for Wellness and Recovery. We need alternatives to opioids, drugs that can provide strong opioid-like analgesia without hijacking the system of motivation and reward that I mentioned before, and memory that I mentioned before. We need better risk assessment tools, a biomarker that could assess whether an individual is at a high risk of contracting an opioid use disorder if they're prescribed an opioid would be extremely helpful for physicians trying to manage the pain of their patients. And finally, the reversal methods. If somebody has opioid use disorder, how can we reverse that diseased brain back to a normal, healthy brain? These are areas of research that are just of premier importance in this area. So finally, just a few summary points here. Stigma has lots of facets. You know, there's societal stigma, there's self-stigma, there's treatment stigma. All of these things, as we've talked about, they prevent people from seeking help because they're ashamed to do it or they're embarrassed. Addiction is in fact a disease of the brain. It's manifested by compulsive substance use despite harmful circumstances to the person. As I showed, opioids and stimulants can hijack the normal motivation systems, and this alters the normal brain function, including the loss of the executive decision-making capability in the prefrontal cortex. And Reggie, when I saw your slide and I was thinking about this, I think this is what your son was instinctively experiencing. You know, why can't I get my arms around this? I'm responsible. I'm personally responsible to solve this. But he didn't realize that his prefrontal cortex had been damaged by the drugs, and his ability to make executive decisions and just choose not to do it was not within his power. And the transition to habit memory is an emerging area of research that hopefully can lead to new treatment options to reverse opioid use disorder. And then finally, we really need biomarkers to measure opioid use disorder and the propensity for risk for opioid use disorder in patients. So that's really all I had to say. Again, I'm just really grateful to be part of this conversation. Dr. Shrum, thank you for inviting me, and I guess I'm going to hand it back over to you.
Yeah. Well, thank you, Don. I know it's always insightful for me when, you know, you speak and talk about, you know, the brain and really the changes that happen. And I think that's an important conversation for really, you know, getting over stigma and for patients to understand, for physicians, for general society to understand what's actually occurring in the brain and to realize that it goes beyond just making good choices. You know, eliminating the shame and stigma associated with substance use and addiction are key to reaching those who are suffering. The National Center for Wellness and Recovery is developing answers through advanced research strategies, increasing access points to addiction care, and delivering hope closer to home. Our board-certified addiction medicine specialists provide custom care plans for adults and adolescents suffering from substance use disorders and other addictions. The National Center for Wellness and Recovery is participating with mental health clinics across Oklahoma to deliver addiction medicine closer to home, delivering addiction care virtually as well as one-on-one confidential treatment in clinics. Integrated treatment includes medication for substance use disorders, counseling, and behavioral therapy and support groups. These treatments, options, and partnerships will reach people where they are and provide answers, access, and hope. Thank you for joining us today. For more information, please visit the National Center for Wellness and Recovery website. Thank you.